traumatic or infiltrative. So we are not going into details how to evaluate the ptosis patient. Just in nutshell, either it is congenital or vacuum, amount of ptosis, presence or absence of the lead lab, LPS action we have to elicit, by the resection, pagation. Sometimes we have to go for Muller's muscle surgery. Sometimes if there is no LPS action, one can go for frontal sling surgery. And some cases of ptosis may be associated with other structural, vascular or neurological abnormalities, so complex convulsions and conjunctiva. So surgery needed is debulking of the mass, and the need for the surgery both for cosmetic vision and improve vision by clearing the visual pathway. So first we go for debulking of the mass. So please remember always there is a chance of recurrence because incomplete removal, and one may damage the nerves and major blood vessels. So these are the surgical steps. And the most important thing, we undertake a navigating system should try to protect the superficial temporal blood vessel, and we could manage it. So these are the excised tissues, and we sutured in layers. This is the post-debulking surgery. In spite of debulking surgery, there is a complete ptosis and no LPS action. And second stage, we went for frontally sling surgery to mechanically lift the eyelids. So this is a post-sling surgery. So this is the patient when came to us, and this after the end of second surgery, we try to lift the upper lid with frontally sling surgery. So this is another patient I want to show it because here there is a bony defect is there. So one has to be very careful whenever doing a debulking surgery, one should not damage the bone. So coming to discussion, as you know, the complete mass excision may not be possible, and the debulking surgery needed to minimize the mechanical ptosis and improve cosmesis. As far as possible, try to damage the major structure like tarsus, conjunctiva, blood vessels, and sling surgery may be needed at later stage to lift the lid. And associated bony defect has to be ruled out, and patient counseling is an important thing because always there is chance of recurrence. Another interesting patient came with acute ptosis with a binocular diplopia. 30-year-old male came with acute onset binocular diplopia, that is sudden drooping of the right upper lid. There is no history of a decrease of vision, but only important is that a right-sided headache, the temporal area on and off. No history of a heady ocular injury, no history of systemic disease like hypertension and diabetes. So this is the young patient coming with sudden onset ptosis, and whenever lid is elevated, there is a binocular diplopia. The restriction of all movements in all directions in the right eye. You can see there is a right anisocoria, the pupillary diameter is more in the right as compared to the left, and also pupillary reaction is affected. The Bell's phenomena is poor. Visual field was within the normal limit. So now the patient came with acute ptosis with painful multiple cranial nerve paresis. The possible differential diagnosis could be orbital apex syndrome, superior orbital fissure syndrome, cavernous anal thrombosis, brainstem involvement, any intracranial space occupying lesion, ocular myasthenia, but here in that condition people is spared, but in this condition people is affected. So we went for systemic evaluation like lumbar puncture, cardiological, neurological evaluation, chest X-ray, Mont picture, all came out to be negative. And all the routine hematological and special hematological tests also didn't reveal any other abnormalities. So we then went for neuroradiological evaluation. The CT scan, chest, orbit, paranasal sinus normal study. We went for MRI, venography, angiography, brain and orbit, all within normal studies. This is contrast enhanced MRI normal. MR angiography also normal. MR venography was also normal. Then we reviewed the literature. What could be the cause? One part we found that is an ophthalmoplegic migraine, an article by Lal et al. In the year 2010. They described a condition recurrent attacks of painful ophthalmoplegia ptosis following attacks of migraine, and they also postulated that is possible viral etiology, and also they found enhancement of thickening and enhancement of the cisternal segment of the third cranial nerve, and they thought it is reversible, and they used oral steroid and with the hope that will hasten the recovery. And there is one association, the International Classification of Headache Disorders. They give this condition as recurrent painful ophthalmic neuropathy, RPON. And they postulated that if there is at least two attacks of ophthalmoplegia, painful ophthalmoplegia, unilateral headache, that is involvement of third, fourth, sixth cranial nerves, and orbital, paracellular and posterior fossa lesion excluded, all patients develop RPL against a backdrop of long-standing migraine. If there is a history of migraine coming with sudden drooping of the eyelid and painful ophthalmoplegia, one should think about the condition of ophthalmoplegic migraine, which is now known as recurrent painful ophthalmic neuropathy. The based on history, clinical examination, laboratory and radiological investigation, a diagnosis of recurrent painful ophthalmoplegic neuropathy was made, otherwise known as also ophthalmoplegic migraine. It is a diagnosis of exclusion. So we started with systemic steroid 1 mg kg body weight initially, gradually the recurrent attacks are possible, so close follow-up is already needed. As you know, the ptosis management based on etiopathogenesis, simple uncomplicated ptosis, surgical management is straightforward. But in the case of complex ptosis, that thorough clinical follow-up is required, thorough workup is required. There may be need for neurological investigation. We may have to ask for multidisciplinary approach, and the stress surgery, that is stepwise surgery, may be needed in specific cases, and medical management may be needed in specific cases like ophthalmoplegic migraine, that is RPOM. Thank you.
Right.
But I did it in stress manner. I never attempted one stress.
Yeah. Deep dive and kind of sometimes you find the LPs really thickened. I tried to kind of explore whether the same LPS, because the function of the LPS may not be that bad. It's just that it's infiltrated with the tissue and it can be thick, So I try as much as possible, if I get an NF. I really get excited when I get an NF case.
I also.
Yes, because it's exactly, yeah. So I might go and try and explore the LPS if possible. I might just come and do a supramaximal LPS resection also in those cases. Correct. Yeah. So I also put a traction suture. Whatever tissue that I see. After I enter just kind of trying to, I try to actually
find that I would probably talk a little bit about some exorbitism or subluxation of the left eye was worse, and you can see this picture is taken after the tarsorrhaphies had been done in an emergency, and there was clearly a mid-phase hypoplasia and a mandibular pronathism. So all of these features, and that's just to give an impression of how the situation was, and it was quite often for the left globe to subluxate. Few other things, there was a high arched palate, hypoplastic maxilla is what I've talked about, there was a malocclusion dental, and I've talked about the pronathism. The hands and feet pictures have been shown because I'll come to that, but these were okay, he was. And the child's, mental abilities were also, there was no delay there, and that was alright. Ocular examination I've sort of talked about, but there was clearly a deviation in exotropia, 45 degrees, and there was tarsorrhaphy, and there was limited motility that was noted. So we knew we were dealing with a craniofacial dysostosis, and there was exotropia, optic atrophy had already set in, there was a syndrome that we had to deal with. And imaging on the right is our patient actually. On the left is a normal representative, and just shows that on the top panel, which is the sagittal scan, tends to show it literally has no floor. There is nothing to support the globe. And the bottom 3D reconstruction again shows just how much of hypoplasia that is there in the midface. Now, in this particular, we know that there is premature fusion, and that's exactly what craniosynostosis is all about. But what are the different? We were talking about these ones, Cruzon, Airport, Pfeiffer, and a few others. But looked like we were probably going towards the Cruzon. Why? Because shallow orbits, most of the features were fitting in. And the biggest reason of the others not being is almost all of them have syndactyly or something in the fingers and all, and that was okay. So we were dealing with a Cruzon. Okay, so we know that much. I've talked about this. Now this is keeping the situation that was there, and I forgot to mention there was obstructive sleep apnea. So we set this up, and we thought that amongst the different things that we had in mind, let's do a reconstruction of the face. And oh, that's interesting. The video isn't playing. So Video to play karte rahe? Probably escape kare ho. We just checked this 5 minutes ago and it was the orbit, the mid face and the upper jaw, all three. And I'm trying to represent that with a schematic there, and that's how it runs. All of this advanced. Okay? So frontozygomatic taken care, that's what we are doing. Then we go into the inner line a few millimeters beyond the orbital rim. That's what we do. All that done. Now the key thing is the whole thing has to be advanced, and this is a little bit of a scary maneuver, and usually at this stage what the maxillofacial surgeon does is they have two large prongs which they fit into the nose, and you will see that come. Yeah, CSF is definitely, but CSF is more about where you are taking the superior one. If you go into the frontal area, up there. But there we were okay, we were going down, so we were fine there. There was no leak. So now that it is just advanced and internal fixation done. You have the option of also doing what is called a distraction osteosurgery. Right, that's a possibility. Now what you have done is you have advanced. That part of the bone is not going to grow the same. Right? It's going to be there. It's going to be a differential. But amongst the many techniques that have been talked about, this one does fairly well. But the surgery of choice today, from what I hear, is you may still do the Layford 3 that we did, and this is called a Tessier's modification of Layford 3. But you can possibly the kind of advancement of choice is distraction osteogenesis, where you fix plates and you actually turn the screws. You teach the parents to do that, and then it advances a few millimeters. That way, the challenge on the vascular bundles is less. What we did was a little more dramatic, but more riskier. I'll come to case 2. Little switch gears, retinoblastoma survivor. At the age of 2 years, she underwent retinoblastoma, enucleation, unilateral, did well, survived. She came to me when she was 16. I'm showing you pictures when she is 23. At 16, I don't have pictures, I'm sorry. But at 16, we somehow did a little bit of fornix formation. There was no implant, but the right side was radiated, and there was a clear difference. And that was her concern. We managed to fit a prosthesis in at that time, but at 23 she was concerned and she wanted to get married. Looking at how's the 3D reconstruction, I'm trying to show you that if I draw a line, horizontal line at the inferior orbital rim, and if that is the middle line, then I've also drawn a vertical line. Then just how different are the two orbits. So if you have to do something, you have to first start from with the bony skeleton being different, which is the skull. So we are looking at again a mid-face being a major problem. We are looking at an orbital volume which is a problem. And we have a little bit of asymmetry in the lower face, but I knew that was beyond what I could do. And then we put onlay grafts and fat to cover up the additional spaces, or the extra volume that was created, or the negative volume that was created by advancement. We filled with onlay grafts and taken from the iliac bone. We also did some bit of fat transfer. And to just make matters a little more, I also did a socket reconstruction with the second orbital implant. That's after the first surgery. Okay? So we are a little better as far as the facial symmetry, and you can look at the malar prominence and all that, but we still have quite a bit on the socket. Now, I'm just trying to show again the skull. And here you see what we had done. You can see the mini plates, and the section of the bone that I showed has been advanced. And that has filled in very well actually, if you look at the right side. So that was the difference that I had. And this CT was done about a year after the surgery, so quite a lot of time. This is where there was obviously surface loss, a very bad socket to deal with. Initial surgery, I managed to do with a lot of actually I took glucosa, but I tried, it was bone dry, so I thought, and I actually found out and also talked, but essentially when I took nasal glucosa, because the secretion is more, it became a little more wet. I took it from the floor of the nose with an endoscope. But again, the ptosis was a problem. So I did a frontalis flap for her, and this is after a frontalis flap, a lid crease creation, not the best of contours, but how she looks. And this is how she looks today. So what I'm trying to say is these cases are challenging. You do staged procedures. You may never get to the point where you imagine you will be. I don't know whether she's going to get married, but I know that when the day she gets married, I'll get an invitation card for sure. Okay, so but they are very gratifying that way to know that you could make a difference in whatever way. The last case I have is a very quick one. This is a recent one. Very recently seen a young girl again in just less than 20, 19 years of age. She has actually a left side cleft. Now the cleft lip had been repaired, as you can see from the scar. But unfortunately the cleft palate was still persistent. And she was not even talking properly, but she had managed to at least eat and drink that she had learned. And again with the same facial asymmetry. I'm just showing you this, the 3D, and in the 3D reconstruction you can see that the cleft in the bone very clearly in the top panel. So that was the cleft. And again, if you see on the coronals, there is no pneumatization, there is no sinus at all. So that's the challenge that we have. Here, we tried to do an onlay graft. We took iliac bone, we placed on the rim. So the top one that you see, I don't know whether my cursor is seen there. Yes, it is. So this is what we took and is actually forms the rim, the new rim. And below is an onlay graft. So these ones are onlay grafts, okay? And then we filled the rest of space that you see with fat. That's what we did. The onlays is too big. But the challenge is onlay will resolve more. It takes more time for the vascular supply to come in and out. And that's her. And she's just about 2 weeks after surgery. She's gone back to Assam. I'm hoping I might need to. I didn't mention, but on the right side, we debulked the cheek that was bulgy. And we also did eyelid reconstruction of the lower eyelid and did a evisceration of the implant on the right side. So we are still on that journey. I just wanted to share. So essentially, that's all I have. Challenging cases, but I think it's all about trying to put in different techniques. It's always a team approach. But sometimes you can make a difference, sometimes there are challenges, but essentially if you've talked it all with the patient, it makes a big difference. Thank you. That's a very good question for the left eye. And you know what, since you're asking, I'll go back and see. Now this one, 1 minute. So this one, left eye, I actually forgot to mention. The reason I didn't do for the medial canthus is because I actually did from the nose a non-endoscopic endonasal DCR. So we had actually done a DCG in this patient. And she came saying that the system is blocked because she had clear epiphora. I knew there was no way there was a patent system. But the DCG was not properly done, and they gave me a report saying the DCG shows patency, whereas actually it was not patent. It was only collecting in the cheek. And in the OR, I irrigated and I found it is not. But when I was opening the orbit and doing all the sac, and sac was enlarged, then what I did is on the table.
No palpable lymph nodes. The general examination was within normal limits. Yeah, we can see that both the upper and lower eyelids as well, swelling in the left eye. There is erythematous overlying skin with matted eyelashes, and the eyelids we were not able to open it because it was quite tense. But as far as we could open, this is how it looked. And with the clinical picture, we could suggest that it was a case of orbital cellulitis complicated with an abscess. Here the pus pointing could be visualized. So differential diagnosis we thought in the mind was maybe due to orbital retinoblastoma, rhabdomyosarcoma or orbital lymphoma with secondary infection. Probably due to the orbital cellulitis caused due to these. Then we did the investigations. The WBC count was raised. We sent for blood culture. We did an urgency MRI brain in orbit. This was the MRI which showed multiple loculated swellings with fluid collection. That those were pushing the eyeball superiorly. And we started on IV antibiotics. injection vancomycin, ceftriaxone, metronidazole, according to our orbital cellulitis protocol. And she was planned for the orbital abscess drainage and diagnostic nasal induction. And it was a soft stop. So I thought to do. So the final diagnosis we made was that orbital abscess secondary to a congenital nasolacrimal duct cyst. So this was a presentation, and at post-op day 1, the swelling has reduced so much and the eye looks a little bit white. Then she was on antibiotics and we discharged her. But 2 weeks later, she again presented with this acute acrocystitis, and we did a NCCT, where we could see that the outpouching was it had there's a loculated swelling in the lacrimal sac area. So then we again did the endoscopic drainage of that. I'm not able to open the video. So then we took the patient for endoscopic drainage of that nasolacrimal cyst. So we did the probing and probing. Then from the punctum, all the pus was coming out. We could see the outpouching in the inferior meatus. We gave the incision and all the pus was drained out. We put a probe. Put on the next video. So we could see the nasolacrimal duct opening in the inferior meatus. The probe is inside the inferior meatus. So the remnant cyst was excised, and then we put the intubation tube. Stay fast for you. Fast forward करते So the remnant of the cyst wall was excised, and then we put the intubation tube, and the tube was removed at 6 weeks, and she was asymptomatic for epiphoria for last 1 year. Congenital nasolacrimal duct cyst, it is the unperforated Hasner's valve showing an inferior prolapse and thereby occupying the inferior meatus. It's also known as the dacryocystosis. It is seen in, it is very rare and seen in with or without nasolacrimal duct stenting is an effective and safe procedure. So the learning points are
and start in a practice. So have a long-term vision, but set realistic goal and go stepwise. Set a new goal once you achieve that. Strive for perfection, because consistency is what can get you to perfection. You need not be the best in the batch or the smartest or the most popular one. So there was a story where it's said that a sculptor was making an idol, and at the end of the product he used to break it and remake it. Somebody asked him, why are you breaking it? It's looking beautiful. He said, I am not happy with the outcome. So please look into yourself and try to be your own judge and strive to be better. Be truthful, it pays. A CEO had 5 employees whom he wanted to succeed. So he gave them 5 seats, all damaged, and said, all of you plant them and come back after a year. Anyone who gets me the best plant will succeed this chair. So all 4 of them came back with healthy looking plants. One of them came with a pot which was empty. So you know, so who won the chair? Gita says, work without expecting a reward. Do what you think is right without thinking what the results will be. There's a story of Paderewski, who was a famous pianist, and he helped few people, including Howard Hoover, to organize an orchestra and earn money for their education. 40 years after, there was a World War II and he became the Prime Minister of Poland. He asked for help to United States President, who was Mr. Howard Hoover, and immediately US allowed funds to go and build Poland. So this is how the rewards come. You never know how, when and how. Value yourself, value others as you value yourself, because each of us are unique. A dollar which is crumpled and thrown is still a dollar. It has its own value. All of us are diamonds and waiting to be polished. The professor, there's a story where a professor called his pupils and gave them a cup of coffee in various beautiful looking cups. After that, he asked each of them to give some comments. Somebody said, porcelain is very nice. So all these comments he heard and said, what you all forgot was the coffee, which is your life. So you do not look into your life, rather look into things outside and get motivated and take wrong decisions. Being ethical is very essential. It is more profitable in the long run, and patients are not fools. You can fool them once, but you cannot fool all patients all the time. Moreover, you should become a role model so that your juniors follow. Behavior towards your colleague is important, and never say, my God, who has done this to you? Always share what you learn, what you know. Empathize with your patients. There's a writer, Maya Angelou, who said that I have learned that people forget what you said. They may forget what you did, but they never forget what you made them feel. The same thing applies to patients. So please empathize with them, communicate with them, put your shoes into their pain, discomfort, and try to do whatever best you can to alleviate. Practice perseverance and patience. Do not give up on your dreams, your values, and your patient, because diamond is just a charcoal. The only difference is that it has handled the stress rightfully to evolve and become the valueless that thing is. Finally, all of us are going to age one day, so let us age slowly, having a contented life, cultivate friends, cultivate interest and hobbies in things which are beyond your science, spend time with family, have some good me time and exercise, which I don't of course, but that we should start from now. And thank you.